Page 55. Diabetes Solution, by Dr. Bernstein. Part 1. Before you start. 1.3. Blood sugar normalization, restoring the balance. According to the NIH National Institutes Health, approximately 233,600 people died in 2005 from diabetes, but it is likely that most deaths due to diabetes are underreported. Is a diabetic's death from heart disease, kidney disease, or stroke, for example, really a death from diabetes? It is the NIH's contention that the risk for death among people with diabetes is about twice that of people without diabetes of a similar age. Certainly everyone has to die of something, but you needn't die the slow, torturous death of diabetic complications, which often include blindness and amputations. My history and that of my patients support this. The Diabetes Control and Complication Trial, DCCT, conducted by the NIH's National Institutes of Diabetes and Digestive and Kidney Diseases, NIDDK, began in 1983 as a 10-year study of type 1 diabetics to gauge the effects of improved control of blood sugar levels. Patients whose blood sugars were nearly normalized. My patients' blood sugars are usually much closer to normal than were those in the intensive care arm of the trial because of our low-carbohydrate diet, had dramatic reductions of long-term complications. Researchers began the DCCT trying to see if they could, for example, lessen the frequency of diabetic retinopathy by at least 33.5%. Instead of a one-third reduction in retinopathy, they found more than a 75% reduction in the progression of early retinopathy. They found similarly dramatic results in other diabetic complications and announced the results of the study early in order to make the good news immediately available to all. They found a 50% reduction of risk for kidney disease, a 60% reduction of risk for nerve damage, and a 35% reduction of risk for cardiovascular disease. This reduction continues to this day, many years after the study was terminated. I was present at the meeting where the results were announced and was congratulated by many of the physicians who had previously endured my long-term insistence that diabetics were entitled to the same blood sugars as non-diabetics. I believe that with truly normal blood sugars, which many of my patients have, these reductions can be 100%. The patients followed in the DCCT averaged 27 years of age at the beginning of the trial, so reductions could easily have been greater in areas such as cardiovascular disease if they had been older or followed for a longer period of time. The implication is that full normalization of blood sugar could totally prevent these complications. In any case, the results of the DCCT are good reason to begin aggressively to monitor and normalize blood sugar levels. The effort and dollar cost of doing so do not have to be remotely as high as the DCCT's findings suggested. The insulin-resistant diabetic, type 2. Different from type 1 diabetes is what is officially known as type 2. This is by far the more prevalent form of the disease. According to statistics from the American Diabetes Association, 95% of diabetics are type 2. Furthermore, as many as a quarter of Americans between the ages of 65 and 74 have type 2 diabetes. A study published by Yale University in 2002 found that 25% of obese teenagers had type 2 diabetes. A new category of pre-diabetes has been recently called latent autoimmune diabetes, or LADA. This category applies to mild diabetes with onset after the age of 35, in which the patient has been found to produce an antibody to the pancreatic beta cell protein called GADA, just as in type 1 diabetes. Eventually these people may develop overt diabetes and require insulin. When the symptoms of diabetes finally occur, they are often more severe than at the onset of type 1 diabetes. Approximately 80% of those with type 2 diabetes are overweight and are affected by a particular form of obesity variously known as abdominal, truncal, or visceral obesity. It is quite possible that the 20% of the so-called type 2 diabetics who do not have visceral obesity actually suffer from a mild form of type 1 diabetes that causes only partial loss of the pancreatic beta cells that produce insulin. If this proves to be the case, then fully all of those who have true type 2 diabetes may be overweight. Obesity is usually defined as being at least 20% over the ideal body weight for one's height, build, and sex. While the cause of type 1 diabetes may still be somewhat mysterious, the cause of type 2 is less so. As noted previously, another designation for type 2 diabetes is insulin-resistant diabetes. Obesity, particularly visceral obesity, and insulin resistance via the inability to fully utilize the glucose-transporting effects of insulin are interlinked. For reasons related to genetics, see Chapter 12, Weight Loss. If you're overweight, a substantial portion of the population has the potential when overweight to become sufficiently insulin-resistant that the increased demands on the pancreas burn out the beta cells that produce insulin. These people enter the vicious circle depicted in Figure 1.1. Note in the figure the crucial role of dietary carbohydrate in the development and progression of this disease. This is discussed in detail in Chapter 12. Figure 1.1. The vicious circle of insulin resistance. Insulin resistance appears to be caused at least in part by inheritance and in part by high levels of fat in the form of triglycerides released from abdominal fat in the branch of the bloodstream that feeds the liver. Transient insulin resistance can be created in laboratory animals by injecting triglyceride fat directly into their liver's blood supply. Abdominal fat is associated with systemic inflammation, another cause of insulin resistance, as are infections. Insulin resistance by its very nature increases the body's need for insulin, which therefore causes the pancreas to work harder to produce elevated insulin levels, hyperinsulinemia, which can indirectly cause high blood pressure and damage the circulatory system. Excessive levels of insulin in the blood down-regulate the affinity for insulin that insulin receptors all over the body have naturally. This tolerance to insulin causes even greater insulin resistance. So, to simplify somewhat, inheritance plus inflammation plus fat in the blood feeding the liver causes insulin resistance, which causes elevated serum insulin levels, which cause the fat cells to build even more abdominal fat, which raises triglycerides in the liver's blood supply and enhances inflammation, which causes insulin levels to increase because of increased resistance to insulin. If that sounds circular, it is. But note that the fat that is the culprit here is not dietary fat. Triglycerides are in circulation at some level in the bloodstream at all times. High triglyceride levels are not so much the result of intake of dietary fat as they are of carbohydrate consumption and existing body fat. We will discuss carbohydrates, fat, and insulin resistance more in Chapter 9, the basic food groups. The culprit is actually a particular kind of body fat. Visceral obesity is a type of obesity in which a special kind of fat is concentrated around the middle of the body, particularly surrounding the intestines, the viscera. A man who is viscerally obese has a waist of greater circumference than his hips. A woman who is viscerally obese has a waist at least 80% as big around as her hips. All obese individuals and especially those with visceral obesity are insulin resistant. The ones who eventually become diabetic are those who cannot make enough extra insulin to keep their blood sugars normal. Though treatment has many similar elements, and many of the adverse effects of elevated blood sugar are the same, type 2 diabetes differs from type 1 in several important ways. The onset of type 2 diabetes is slower and more stealthy, but even in its earliest stages abnormal blood sugar levels, though not sky-high, can cause damage to nerves, blood vessels, heart, eyes, and more. Type 2 diabetes is often called the silent killer, and it is quite frequently discovered through one of its complications, such as hypertension, visual changes, or recurrent infections. Type 2 diabetes is, at the beginning, a less serious disease. Patients don't melt away into sugar water and die in a few months' time. Type 2, however, can through chronically but less dramatically elevated blood sugars be much more insidious. Because so many more people are affected, it probably causes more heart attacks, strokes, and amputations than the more serious type 1 disease. Type 2 is a major cause of hypertension, heart disease, kidney failure, blindness, and erectile dysfunction. That these serious complications of type 2 diabetes can progress is no doubt because it is initially milder and is often left untreated or treated more poorly. Individuals with type 2 still make insulin, and many will never require injected insulin to survive, though if the disease is treated poorly, they can eventually burn out their pancreatic beta cells and require insulin shots. Because of their resistance to the blood sugar-lowering effects of insulin, though not its fat-building effects, many overweight type 2 diabetics actually make more insulin than slim non-diabetics. Page 58.